So what does it look like? This is just like everything else. It's flu symptoms, yay! We already see these patients on a regular basis. We run hundreds of them a year. So now all of a sudden there may be these patients presenting that also have this complex illness. So fever, cough, upper respiratory infection, sore throat. I actually just read there was a case study of patient one in the United States. And interestingly, he actually described diarrhea. But the WHO is saying that nausea, vomiting, diarrhea is not in the symptom profile. But what we're typically seeing is what we see with any other respiratory infection, lower respiratory infection, which is cough, fever, sore throat, shortness of breath. So how does that change the way we respond to these patients? We'll talk about that a little bit, but essentially, these are folks that we're interacting with every day. I mean, who's run a fever call in the last couple of months, right? Everybody. So this is going to fundamentally change the way we run these patients, independent of whether we think they have COVID, because the COVID part is less important to us because we just don't have the sensitivity. The absence of fever does not rule out viral presence, so most patients have a fever, but not all. So if you're hanging your hat on fever, that's probably not a good decision to make. The potential, if they have a fever, is higher, but just because they don't doesn't mean that they don't have this infection. An interesting thing about the contagiousness of this disease, so most viruses, the level of the amount of symptom that you have is correlated to how infectious you are. This disease sheds virus at the same rate, whether you're low-level infection that just feels cruddy or whether you're in the ICU. So the important part about that is you may not feel that sick, but you're still very contagious. And so for you guys, from a work standpoint, I'm not your boss, but I don't want you guys running calls if you don't feel well. And we're telling our folks, if you don't feel well, call in sick. I'd rather have 2 ambulances on the street instead of 3, but have healthy employees. Because the big issue here is if we start having infection propagate in our agencies, it's going to really affect our business. It's going to affect our ability to run calls. Because 30% infection rate is not unheard of. And imagine if you guys had to function with a third of your staff being gone, it would be very difficult. So right now, and for the last 2 weeks, we've been asking travel questions at dispatch, right? Yes. You're covered, you're slowly going into your cocoon. So we've been asking travel questions, and we're basically asking people if they've been to the big 5 countries, so China, South Korea, Japan, Iran, Italy. That is probably going to become less and less useful in the days and weeks, because as we get community transmission that sort of moves throughout North America, it's not going to matter whether they've been to China before. In fact, one of the cases in Colorado right now, they think was a community transmission case, and the travel history was California. So my wife got mad at me because her aunt was in town from California this weekend, and I said, not no, but no. And she's like, well, blah, 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 blah. And I said, no, they have community transmission in California. I'm not interacting with people from California. I'm not. And I've been like totally immersed in this for 2 weeks, so maybe I'm a little nuts. But it's just not, it's not worth it. It's not worth it. I don't want to get sick. I don't want to get other people sick. I don't want to potentiate the infection. So again, if you're sick, stay home. I know a lot of us are soldiers and we kind of move on even if we're sick. And if you're sick and you're fever and you feel like a crud, just stay home. Give it a couple of days so you can recover. So the travel questions will likely be eliminated. It's still a tool. If you hear that they were hanging out in Wuhan for a couple months and they have all these symptoms, the likelihood is they probably do have COVID, but it's not something, again, to hang your hat on. They could potentially not have any travel history and have employment at the airport where they're interacting with a lot of people, and that was enough for them to be. So, any questions up to this point? I know it's really good news. So what are we doing for it? So there's no vaccine. There are 3 that are going to clinical trial. I think the one in Washington just went to clinical trial this week. What's wrong?
I was just told to avoid people from California.
Okay. Well, I mean, generally avoid people. I would generally avoid people from California, but then now even more specifically.
Now we just have a reason.
Right, now you have a real reason. So there are vaccinations in clinical trial, which is really, really good news. As people have described, this is the fastest we've ever had a disease be discovered and go to the clinical trial on vaccines. So that's great, and the technology's there, and they're working really hard. It's a 12 to 18 month thing. So we're not going to see a vaccine in this cycle of the disease, if there is a cycle. We don't even know. So don't plan on that. Don't be like, yeah, I'll just hang out and get the shot. Everything will be good, because we're likely going to go at distance of time. as this moves to the community without any sort of vaccine. What is interesting is therapeutic trials, so they're looking at a bunch of antiviral medications, so medicines that are used for stuff like HIV, which apparently there's a conspiracy theory now that this is related to HIV because they're using those drugs. That's not true. They just are antiviral drugs, which is, they're good against viruses. AIDS is a virus, so is this. But there's a bunch of therapeutic trials going on. The case that was described in the literature yesterday, they used an antiviral drug on him because he had viral pneumonia secondary to this, and it was helpful. So if there's a chance that in the next weeks and months we're going to have a clinical profile, it won't be anything we do pre-hospital. So pre-hospital, what we're doing, and the number one thing that we're doing as practitioners is isolating ourselves from the patients. And I can't stress this enough. These people typically are not going to be acute. They are going to be sick and sad and feeling like they're in bad shape because they think they have COVID, or that just sucks to have fever and the flu and that sort of stuff. They are not emergency patients. And because of that, we do not need to put ourselves in harm's way unless there's a reason to. And I'll talk a little bit more about that. But the number one solution for us right now in treating these people is keeping ourselves safe and isolated from the disease. People die of pneumonia and adult respiratory distress syndrome, sepsis, so all the sort of same stuff that people die from when they have infections. And what we're essentially doing is just making sure that we manage symptoms. If we do have somebody that's critically ill, it's totally possible that you'll have someone that is in a risk category that also needs critical interventions. Then we're, with proper PPE, going to perform all those interventions that we would typically perform. We're not going to watch them die, but at the same time, we're going to be really conscientious of the treatment we're providing to these patients and how it affects us, and making sure that we're keeping ourselves safe. Because at the end of the day, our job is not just the call we're on, our job is maintaining the structure of the system. And if we are all getting sick, the system is going to collapse. So we want to make sure that we keep ourselves as safe as possible. So what we're doing, what Gilpin Ambulance is doing, is we are limiting the number of people that are coming in contact with any patient that falls into this criteria. I'll show you the algorithm here in a second, but essentially, if we have a patient that falls into this fever, respiratory illness, potential travel history, all those sorts of things, we're only putting one person in contact with that patient. We are not putting two paramedics in a room with a person that potentially has an illness. And I would say to you, this is a judgment call for you when you run these calls. And I think the default to Chief Onder about exactly how you do protocol for running these calls. But my opinion is we shouldn't, of any agencies, we shouldn't put anyone with one person if it's a subacute or non-emergency illness. So we get the call for the 40-year-old that has fever and chills and cough and shortness of breath for 3 days, and they're talking in normal sentences, and they just really don't feel well. We're going to send an ambulance. We're going to have one person in full PPE go in, contact the patient. They're actually going to toss the patient a surgical mask from a distance. So if that's from the door, they're going to toss, this is CDC guidance, so don't laugh at me. They're going to toss a surgical mask to the patient, have the patient mask themselves, because that significantly reduces the amount of transmission. And then once the patient's masked, they'll approach, they'll do an assessment, and then we'll try to get to an understanding of what we're doing. Some of the stuff we're not going to do. We're not going to do aerosol generating stuff, so we're not going to give nebs, we're not going to suction people, we're not going to do intubations unless they absolutely need it. So we're going to be really conscientious about the care we provide and how that exposes other people. If we need to intubate somebody that is potentially infected, we're going to do that in the back of the ambulance with all the doors open, all the AC stuff running, so we can have as much ventilation as possible. But we're going to be really conscientious about making sure that we only use those treatments for people that really, really need them, because that is something that is potentially really complex. Obviously, if someone is critical and they need critical interventions, then we want you to make contact and take care of them. But I would suggest just the number of people that needs to. So, you know, if the person needs oxygen and needs to, you probably only need 1 or 2 people in that room. You probably don't need 6 people in that room. If you put 6 people in that room, you're just exposing 6 people, and that, you know, it's a numbers game. So the more people that are exposed, the higher likelihood you have one person that becomes infected. The more people that become infected, the more likely there is propagates through your agency. Stuff we're going to do, so we're going to take all the shit out of the back of the ambulance, the laptop, all the other stuff, we're taking it out of the back of the ambulance on these particular calls. And the way you can help us is if we get one of these calls and our paramedics are there taking care of the person, our EMT or other paramedic will help direct taking stuff out of the back of the ambulance. So the monitor and all the, soft goods stuff, anything that's not in the cabinet, we're gonna chuck. The laptop computer, never gonna be in the back of the ambulance because it's a huge vector of infection because it's just they're filthy. So we're gonna try to do what we can to manage the infection being spread in the back of the ambulance. And, this is a droplet sort of thing. So I cough or sneeze, not in my jacket or and I'm putting out airborne droplets with up to about 3 or 4 feet around me. As we understand from the CDC guidance, this virus will live up to 9 days on surfaces. So I'm in here today and I cough and then touch all this crap, and then you come in here in 3 days and it hasn't been cleaned, and you touch it and you put your hand in your mouth, put your hand in your nose, put your hand in your eye. Now you have potential sort of contact with infection. Now it doesn't mean you're going to get sick, because we have immune systems and they work and they see things and they destroy them before they even take hold in our bodies. But that's the way that you become infected. This isn't an airborne virus. It's not something that's floating around in the air waiting for us to breathe in like tuberculosis is. This is droplets. And that's why the surgical masks are really, really effective when they're on the patient, because they contain all those droplets, so they're not being sprayed all over the place. Any questions about that? So this is what we want you guys to wear. I want you to look like this too. So all the normal stuff we wear, if we're on an infectious patient, you should already be wearing a mask if you're dealing with someone that has a respiratory infection, right? If you're dealing with, especially in flu season. And I'll give you my thoughts on the flu shot too. You should all have the flu shot. And it's not because you don't want to get sick, it's because you are potentially a vector that moves the flu from someone else to someone that has a disabled immune system and they could kill them. So if you don't have the flu shot, there's still time. But we want you to wear gloves, an N95 mask, so not a surgical mask, but an N95 mask. That's the minimum standard for this disease. A gown, or any sort of thing that protects your clothing, and eye protection, and not glasses, not your sunglasses, but goggles or a face mask. So something that's actually going to stop droplets from entering your mucous membranes. This is super important. And I know this is going to be the big issue because there are not a lot of N95 masks. What we have done at the Ambulance Authority is we have issued every employee a mask. These masks can be used up to 5 times, as long as they don't get saturated with body fluids. And that's a CDC guideline. It's not the best deal. That's not what we want to do, but we have a limited supply of masks too. So up to 5 times, and the caveat to that is you wear an N95 mask and then you wear a surgical mask over it. So that surgical mask over it is giving a little protection for the actual droplets. And then that mask has to be stored properly, and we'll show you a little video. The gown is really important. So the gown, I put an asterisk by because we don't like wearing gowns in EMS because we don't like the word gown. But I'll tell you that, you go on this patient and you have an incidental contact where they cough on you and you're wearing all your PPE except for a gown, and you get the droplets on your shirt, and you go back and you sleep in your bed, and you spend a 48-hour shift in that shirt, that you have a high likelihood of having some potential transmission. So if you aren't lucky enough, or you walk in maybe and you discover the patient is sick and you don't have the opportunity to put a gown on, it's super important that you launder your uniform when you get back. Like come in, strip in the garage, take the outer layers off, throw them in the wash. The cool thing about this virus is it is totally destroyable with normal infection control stuff, Lysol and 409 and all the cavi wipes and all the stuff that we typically would use. So we don't need any special Herculean things to kill it. We just need to throw your clothes in the laundry. But make sure you launder your stuff, and that's hats and boots, like get everything clean. You really, really shouldn't be wearing bunker gear on medical calls at all, but especially in these circumstances because it's just hard to get that stuff clean. So do the